Roberto Leon Ferre. I'm a medical oncologist focused in breast cancer. From a clinical perspective, I see exclusively patients with breast cancer, and in terms of research, my interest is in triple-negative breast cancer, which is the most aggressive subset of tumors. And I also do research in the immunotherapy space, focused in triple-negative breast cancer. Well, I think over the last several years, we've seen a lot of interesting data, suggesting that immunotherapy is here to stay. In breast cancer specifically, we've been a little late to the party, if you will. We've seen a lot of data in lung cancer, melanoma, and we're now starting to implement immunotherapy in breast cancer as well, particularly in the more aggressive subtypes such as triple-negative and HER2-positive breast cancer. What's interesting about this type of agents is, one, as we know, these drugs do not target the cancer cells specifically, but they rather unleash the immune system so that the immune system can go after the cancer cells. And because of that, immunotherapy has the potential to work in multiple cancer types and not be restricted to one tumor type. In addition to that, they're generally very well tolerated and better tolerated than most chemotherapy drugs. So I think that we could envision, hopefully, a future where we are de-escalating our chemotherapy drugs that are the ones that tend to cause most of the side effects of cancer treatment, and perhaps start escalating our immunotherapy approaches once we understand a little bit better which patients benefit from that approach and which don't. Well, it's affecting it on a daily basis. Today, we have started to migrate from an era where we looked at the tumor in a very, if you will, archaic way, in which we decided how to treat patients based on how big the tumor was and how advanced it was. And now we have gained a lot of understanding about the biology of tumors, including genomic profiling of different tumor types. And now we understand that biology and that genomic composition of the tumors may be much more important than how big a tumor might be at the moment of presentation, as it can help us tease out specific vulnerabilities of each tumor that can be targeted in a little more specific way. So in breast cancer specifically, genomic profiling has been around for many years, and we have increasingly been able to give less intensive chemotherapy drugs, for example, to patients that have favorable genomic profiles in the case of ER-positive breast cancer. And in the more aggressive subtypes, such as triple-negative breast cancer, nowadays we are able to identify specific mutations or alterations that allow us to predict who is going to benefit from each type of treatment. And a classic example is patients that have BRCA mutations, which predispose to breast cancer, are very likely to benefit from drugs called PARP inhibitors. So we're using it on a daily basis now, and I think that this is only increasing, and it's going to increase as more data comes to be generated in those tumor types. Yeah, so I think that the key will be a continuation of personalization of therapy. Rather than seeing patients as having breast cancer and then selecting a drug regimen based only on the subtype of cancer they have, we are going to be seeing an increasing ability to customize and tailor that therapy to an individual patient level based on tools like the genomic profiling. We may have an era where it doesn't really matter as much if a tumor originated in the breast or in the lung or in the liver, because if they share certain genomic characteristics or immunotherapy continues to benefit a lot of these patients, we may be able to treat patients more based on genomics than on tissue of origin. So I think that in the future we're going to see providers involved in oncology care that have a much higher degree of specialization on specific pathways or specific biological characteristics rather than a tissue of origin. No, I think it's a very exciting time to be in this field. Certainly, we are much more able to do helpful things for our patients than we were in the past, and this is a rapidly evolving field that I think will only continue to evolve to help more patients in a better way.